Good afternoon in Australia and selamat pagi in Indonesia. Welcome everyone to day 2 of our conference. My name, for those who are joining us today, is Tim Lindsay, and I'm Director of the Centre for Indonesian Law, Islam and Society at the University of Melbourne. Let me begin by acknowledging the traditional owners of the land on which we stand. In the case of the University of Melbourne, that is the Wurundjeri peoples of the Kulin Nations, and we pay our respects to their elders, both past and present. Thank you all for joining us today, with a special thanks to our speakers from Indonesia and Australia who have so generously given us their time despite the challenging conditions and constraints created by the pandemic. Today's conference is hosted by SILIS and IDeHaRI. IDeHaRI stands for Indonesian Democracy Hallmark Research Initiative. IDeHaRI is a 3-year interdisciplinary research project funded by the University of Melbourne. It has been created to develop deeper understandings of the challenges to the quality of democracy in Indonesia by supporting scholars working on Indonesia at this university through research grants, support for the Indonesia at Melbourne blog, and events like this. I'm Chair of IDeHaRI, Dr. Dave McRae is Deputy Chair, and Dr. Helen Pausaka is our academic convener. The theme of today's conference, as you all know, is assessing Indonesia's response to COVID-19. Today's 2 panels will cover issues related to health and society. Please do stay with us today. We'll run from now until about 4 o'clock Melbourne time, about 2 hours, and we will have 3 speakers presenting in each panel, as well as about 20 minutes for questions after each panel. A detailed conference program is available on the conference website, and I'll just ask Catherine Taylor if she could put the link to the program up on the chat. Thanks. During the presentations, only the speakers and chairs will be visible on the screen. Attendees will not be visible, but you will be able to ask questions in writing via the Zoom Q&A function at the bottom of your screen, and those questions will be answered live by the speakers. Please note that today's event will be recorded and it may be published online at a later stage, and that there may also be members of the media taking part in the conference today. Today's webinar is managed and moderated behind the scenes by Catherine Taylor and Debbie Yu, who are the manager and administrators of SILIS. Speakers and chairs, if you have any problems, technical or otherwise, during the seminar, please email Catherine and Debbie and they'll be able to help you. They'll be busy behind the scenes today, so my thanks in advance to their hard work keeping us all on air. Now, let's go straight to our first session today. So Linda Bennett, Associate Professor Linda Bennett is our chair for this session, but she's unavailable due to some technical problems. So I will step in and start chairing this session until Linda can join us. Our first session is on health and society, and our first speaker is Professor Iwan Ariawan from the University of Indonesia. Iwan Ariawan will be speaking about COVID-19 in Indonesia, looking at the pandemic from a biostatistician's point of view. Pak Iwan, you have 10 minutes, please.
Okay, thank you for the opportunity for me to share my work on the COVID-19 epidemic in Indonesia. So I will share my screen. So I begin with the reported cases of COVID-19 in Indonesia. So this is the reported cases daily that also published in the government website of COVID-19 reporting. So we can see here, actually, the new reported COVID-19 cases is still increasing. We have not seen the peak of epidemic yet. This one, the latest, there are some decreasing, but we are not sure that this is already the peak of the epidemic. So what we conclude from this graph is actually this first wave has not finished for the COVID-19 pandemic in Indonesia. And please also bear in mind that this is based on the reported date. Okay, and then this is the positivity rate. So the positivity rate of COVID-19 cases in Indonesia daily, we can see here there is a trend of increasing positivity rate, and then it is still higher, so 3 times higher than WHO target. So it means that actually the transmission in the community is still high, and the testing is still less in Indonesia. We can see here then the testing. This is the number of testing weekly per 1 million population. So yes, there is an increase of testing, but it's still below the WHO standard of 1,000 tests per 1 million population per week. And this is if we look at the case fatality rate. The case fatality rate is decreasing, but it's still about 5% case fatality rate in Indonesia. And we also need to be careful because actually the definition of COVID death in Indonesia is varies between hospital and between province. So the real COVID death may be higher than this figure. Okay, so that's the current situation. So let's see what will be in the future. So this is what I have done with my colleagues. So we try to model or predict the epidemic in the future. So this is our method. So first, we created the epidemic curve based on onset, because the real epidemic curve should be based on onset, not based on the reported date. And then we fit the epidemic curve during then after large-scale social distancing policy. And then we use several scenarios to see how the epidemic will grow in the future. So, okay, this is just the formula that we use to adjust the epidemic curve from the reported date to the onset date. Okay, and then we use the simple SIR model for this epidemic model. The SIR model, so it has the susceptible compartment, infected and recovered compartment, and then it will derive by the beta here and then gamma coefficient here. So actually, from the epidemic curve, we try to fit the beta coefficient, and then the gamma coefficient is kept constant from 0.1, because the gamma coefficient is the rate of recovery from the infection, which is for now, there is no proven drugs for COVID, so it's kept constant in 0.1. So this is the modeling scenario for the future epidemic in Indonesia. So in Indonesia, we have the large-scale social distancing. So it is more or less similar as lockdown, but it's not as strict as lockdown. And then the government already have the large-scale social distancing policy in March, April, and May, and then it's loosened because of the economic activity should continue. So after the what we call as PSBB was loosened, so we need to depend on the preventive measure, such as washing hand with soap, using face mask and physical distancing, should be done to decrease the risk of COVID-19 transmission in the community, and also test, tracing, and isolation. So this future epidemic curve that we predict will depend on how these two preventive measures above will be done by the community and by the government. So, okay. So this is actually the epidemic curve based on onset. This black line, yeah, the same pattern. Actually, it's still in the first wave of epidemic, the curve is not over yet. Then this is our estimation of the transmission rate. We call it a beta coefficient. So this is before the large-scale social distancing policy. Actually, if there is no large-scale social distancing policy, the epidemic curve will go like this one. But because of the large-scale social distancing policy, it go to this one. Yeah. Now, okay. So it's not as high as if there is no large-scale social distancing policy. Okay. Now let's continue here. Okay. So if we look at the time frame, so it means that during next year, we still should live with COVID. The epidemic will continue to the next year, and then it will be eased by the early 2022. And what happened if the preventive behavior has low coverage, and then test, tracing, and isolation coverage is also low? This is what will happen. Yeah, the peak is higher. So it means if the peak is higher, the person who needs hospital bed and ICU bed and ventilator is also higher, and this will overwhelm the health facility in Indonesia. If we can do better, we can follow the green curve, which is we can decrease the burden of health facility because the number of cases is less than what we have if we are still doing business as usual as now. Okay, so the message from this graph is actually we are still a long way to go with COVID-19 in Indonesia. So
1 minute, Pak.
yeah, Pak. So we are still a long way to go with COVID-19 in Indonesia. So we need to be prepared for it. And this is the predicted cumulative death of COVID-19 in Indonesia. So business as usual, this one, the gray one. So if we want to decrease the COVID-19 death, so what we can do is high coverage of the preventive behavior, and then test, tracing, isolation should be done in high coverage, and also no delay in test, tracing, and isolation. So as conclusion, actually the COVID-19 epidemic in Indonesia has not controlled yet now. And then actually the large-scale social distancing policy has decreased COVID-19 transmission in Indonesia, but it has been loosened. So it should be replaced, or it should be replaced by the preventive behavior and also test, tracing, isolation to strengthen the control of epidemic. And then our model show that the epidemic will last in the next year. So it means that we need to be prepared for the next year to live with this COVID-19, and it only be eased by the this is 2022. Okay, I stop my presentation here, and then we can have more discussion later on. Thank you for the time.
Thank you very much, Pak Iwan. That's perfect timing.
Yeah.
That brings us to our next speaker today. We'll have time for questions at the end of this session. Before I introduce our next speaker, just a comment to participants. You can start entering questions now if you want in the Q&A function at the bottom of the Zoom screen. You don't have to wait till the end of the session, and I will be reading through the questions and direct them to our panelists after the third presenter. So let's go now to our second presenter, Pandu Riono, who will be speaking about why we are failing in our response. Could Indonesia have done better? Dr. Pandu Riono is senior staff at the University of Indonesia's Faculty of Public Health. So, Dr. Pandu Riono, you have 10 minutes. Thank you. Well, while we're waiting to reconnect with Dr. Pandu Riono, I might just use the opportunity to ask Pak Iwan Ariawan a question. if that's all right. Thank you very much.
Yeah, that's okay. Yeah.
The question is, do you think that the reimposing of the PSBB regulations in Jakarta have had an impact?
Yes, because we look at the data, there is an impact on the decreasing of the, not decreasing actually, but decreasing in the transmission rate of the new COVID cases. But this new PSBB is less strict than the previous one. And also the area surrounding Jakarta doesn't impose the PSBB policy like in the first one. So there is an impact, but the impact is less than the previous PSBB one.
Okay. I wonder if there's any other questions for Pak Iwan. Right, well, thank you so much, Pak Iwan.
Yeah,
what I think we might do is, while we're waiting for Pak Pandu to rejoin us, I might actually jump forward to our third speaker instead. So our third speaker is, if you're ready, Hannah, is our third speaker with us?
Problem.
We got Pak Pandu back. Thank you so much, Pak Pandu. Please go ahead. You have 10
minutes. Thank you, Tim. And I will be happy to say that, as Dr. Iwan already presented, that Indonesia currently we are not success yet in the positions the pandemic, and we realize that we don't know where is the peak for this curve, the pandemic curve in Indonesia. And I want to present, based on the three outlines, the current pandemic. I will be fast because Iwan already mentions, and why we have peak pandemic response, and why need to building a new system to need public health reformations. And this is the situation is still, the cases should still going up every day, and it's like never ending. The story is still unending. Go to the top, the mountains, but where's the top, we don't know yet. Maybe this year or next year, but it's very difficult to reach the top in the end of this year, especially because we have another many activities that will be increasing the possibility the cases go up continuously, like Pilkada or the elections, and also another activity that the end of this year, maybe people go to the holiday and go around to the country, and there's already mentioned many times the mobility is very important to influence the pandemic in Indonesia. And this is the situations that we still, the reproductive still above one. It means that this is the problem that we're facing now. And Dr. Iwan mentioned some scenario that it might be like this. Do this like future epidemic curve in Indonesia? We don't know yet because there's so many activity. This is not include the response for a different response, or another strong influence, like the elections of the local candidate, local governments. That's very important in the current situation in Indonesia. And also the death is still going up because the hospitalizations, because the increasing of cases, the hospitalization increases, and then the death is also still increase. Look at the death for the hospitalization, not the death for all COVID, because most the COVID patients is asymptomatic, and mild cases will be cured, mostly 100%, nearly 100%. But the death for hospitalization is very still high. And this is include also the because the comorbidity. And the Jakarta is the best example because 70% of the cases come from Jakarta, and then we can look at the curve, and then how the response that going on in Jakarta, like social distancing or PSBB, have some impact. Like in here, the people increasing stay at home, and then the pandemic is become flat. It means that if we have strong as lockdown, not lockdown, but PSBB, there is will be impact on the decreasing of the cases, but it's not because the government is very difficult to pursue it should be strong lockdown, and even only 1 month they don't want it, and then the possibility is then we enter the reopening the activity, lose the restriction, and then all the Jakarta is increasing again and increasing again, and then we have another the second lockdown, but actually it's just very mild social distancing, not the same with the first one. That's why the even we have increasing people stay at home, but it's not strong enough to influence to decreasing the curve of pandemic in Jakarta. They still getting flat, not going up, but it's up again because people not stay at home. This is important. Why the the current response in Indonesia is unclear, uncertainty. What we want is unclear, and then sorry, and this is Jakarta still like this, and reproductive rate still above 1. It means that it's very difficult to decreasing or to make one curve in Jakarta because Jakarta is open city. We cannot close the city like in Melbourne or another city in Australia, and then it's very difficult too because Jakarta is not Jakarta; it's a big Jakarta. People move around surrounding the city like Bogor, Tangerang, and Bekasi, the big Jakarta. This the area that also influence. If they don't have any intervention, then just like TikTok, move around. They will be decreasing in Jakarta but increasing in Bekasi, and then after Jakarta decreasing, and then they will move again up in Jakarta. That's very difficult to Jakarta to because the response is not coordinated well. And this is the situations. The situation we feel until now, not success until now. Hopefully, we have something in the future, strong idea and building the system. Because in the first response we delay and it's very uncoordinated. And when the government using the quarantine law, and it's very difficult to implement because there's no guidelines from national law to we call it president government's instructions. I mean peraturan pemerintah. Government instructions is not ready yet. Even the quarantine for pandemic is already launching to 2018. It means that our regulation is not ready to helping to guidelines the national response, and also because the authority of the Minister of Health is very weak, and the government suddenly they don't want to Minister of Health become a leader for this pandemic, and then ask the national disaster agency to coordinate the response. They don't have capacity. It is very difficult to disaster agency to coordinate the pandemic. They never know how to do the surveillance. The example, they don't know about the to do the behavior change communication. This is very difficult. Even they have so many experts, but the system is not there. The system in Ministry of Health, the surveillance system is Ministry of Health. They have the system. They don't use the system. That's why the response is very, very weak, and that's very difficult. That's why I push to remove all the task force approach, Then using the government system, because the government system, even we have a weak leader, I mean the weak authority leader like weak of the Minister of Health, but the system already there. We can increasing the system. We don't need people. We need the system. And it means that until now, that's why because they still using task force, they're already two different task force or three maybe, is the gugus tugas, the agency, and then combined with the national economic ministry, and then suddenly to ask one person's ministry to lead the response.
2 minutes.
Again, okay.
2
It
minutes.
means there's no plan of action for pandemic. That's very difficult. And until now, even already know that the surveillance, testing, tracing, isolation is very is already some what call is the strong intervention that already helping some countries success to control the pandemic, and also behavior change communication is not strong enough. They still on low priority. And what is the example? The example people, the government, the leader asking people using masks, but they don't follow. They don't give the example. This is the terrible example of the leader. They say something, but they don't use it and give the example how to use mask in every occasion in the public activity. And it means that the solution is we need public health reformations by building the pandemic response in the governments, because this is not the first pandemic. There will be another pandemic in the future. And then we need also public health reform, especially primary health care, because the contact tracing, promotion, prevention is in the community is very near. This is the first front line for public health services, the primary healthcare, puskesmas, and the the weakness, the fatal, the fatal process. They don't involve the community. The community is the front line of every outbreak response. We should start at the beginning by asking the people to follow stay at home, to follow using masks, and everything is should be involving the community. Thank you. Thank you, Tim.
Thank you very much, Pandu. Thank you. There's a lot there to discuss. We'll hold that for our discussion session after the last speaker. And our last speaker is Dr. Tri Maharani, who works currently at the Daha Husada Hospital and is a member of Lapor COVID. Dr. Tri Maharani is going to speak today about the stigma for survivors of COVID-19. So Dr. Tri Maharani, you have 10 minutes. Thank you very much.
Yeah, thank you, Tim. I will presentation entitled Stigma and Survival in COVID-19. I am an emergency physician, and in June I am have a COVID-19, and I am a patient survivor COVID-19. And now I am will to share my experience in 5 months about COVID-19 disease in my hospital and my working. Before March 2020, I know information about COVID-19 in the other country. And many friends in the other country asked me about it and asked me about the difficult condition of the COVID-19 in my country. And I know I am working in the rural area. It's a very difficult to handling if my town or my hospital and the many patients with COVID-19. And I have many ideas to preventive and promotive of COVID-19. I know the prevention on COVID-19 is hand hygiene, wear of mask, physical distancing, and stay at home. I know it's very simple of the prevention and promotive, but difficult and the really. I have many innovation. You look in my pic and my presentation. I am donation. I was donation many hand wash from plastic and from the other equipment, and donation hand soap and the other from many people and many location in my town. And I was innovation a long stethoscope to helping many doctor and nurses to physical distancing with the patient. I'm saving the overall because this before March, the many store don't have overall, and the good overall is very expensive to my hospital and to my health worker and my town. And I give donation many people, and I'm saving with my sister also mask from cotton and give many people. I was donation a 2,500 masks from cotton because I know it's the good prevention. But in the before math, the many people don't have information about masks from cotton. The mask only in the patient with COVID-19. I think it's the late policy, but I know in this before March, I'm started to give donation of the mask from the kitten to many people. In the April, I will go to the Jakarta and the volunteer COVID-19 in the Sulianti Saroso Hospital Center of COVID-19 in Indonesia. And I look many people in the severe COVID-19, and I know very bad condition. I have idea to record it from this case by case and fatality case and fatality case. I'm calculate one by one cases because I know it's very important data to my country. And in the June, I have one patient, is my staff also, the laundry staff. He is a sick. He was sick with the sign and symptom to the fibrous, nausea and vomit, and all sign and symptom suspect of COVID-19. But in my hospital, not to the COVID-19 center in my town. I must go to the other town to check it with a swab PCR to my patient. And I go with him and help him go to the other town to check it this sick. And in the hospital, this doctor asked me, my patient pneumonia and the severe pneumonia and suspect of COVID-19 because swab PCR need the several days to result. And 5 days after, and 1 days after I go with my patient, I know same I am working volunteer in the Sulianti Saroso. If I was after the race of the patient, I must checking myself to the PCR and swab. And I asked this doctor and the other town, I'm back to 1 days after I go with my patient and I'm checking myself. After 5 days, I know my result from my check it swab PCR. I am positive also, same my patient. In the very bad condition because I am a emergency physician doctor and only one emergency physician in my town. And all my town know I am in the positive COVID-19. It's very difficult situation. I must ask to the Department of Health in my town. I must ask my director of my hospital. I must ask to all my staff because tracing and screening, I think it's not easy to the all my staff and all my friends contact with me and my family also. And I have idea to brave, give information to all in social media. I wrote this my story. I am wrote I am positive COVID-19. I am a doctor and my contact is my patient. I think it's very difficult article because I must brave to give information to all people and my all and in my town because it's very little town. My head of town acts in the radio, and many people, I think in all town, know I am patient COVID-19. I was patient COVID-19 in this June. I have one journalist and helped me to wrote my message from the Minister of Health, Dr. Terawan, because no catret in center of hospital in my town to check it PCR by TCM to many people. And I think it's very difficult problem to the COVID-19 diagnosis. And the stigma start and I go to the hospital because I must isolation. You look in my presentation, yeah, yeah, the condition, no people, the police, the army, and many people afraid go to my home, and this way stop it all people to straight on my way. And the isolation room only me, and the all day only me meet the nurses every X hour. I know it's difficult condition. And this day is not easy day. In the 3 days, I'm changing my mindset. I know I'm a doctor and I must to face this situation and this condition. And I go out from my isolation room every day, 1 hour only to look the side and activity with the other patient in the other isolation room. I gave the happy all patient with the song, with the fruit, biscuit, and the other. I give them because I know if the a little I give something to the other patient, give them happy. And I have many greeting sympathetic. And I know it's the solution to give power to many patients COVID-19 to survive. And I am survived. After I am survived, 10 days I am in hospital and 40 days I am in isolation in my home. I am have the woman of the champion of snakebite because I am president Indonesia Society of Toxinology. And I'm very happy because and I am condition COVID-19. I am still to help many patients in the snake bite. And many friends in the lapor COVID-19 gave me solution with the Pusara Digital. Pusara Digital is the uh, information and the group from the supported many people that after with the COVID and give heroes to many people, health worker or the community with the COVID-19. And I'm have survival COVID-19 group to support it many people with COVID-19, include the health worker. I think in survive in COVID-19 need two important conditions. One, external, prevention, early detection, golden standard diagnosis, PCR and TCM, and have reagent and cartridge, and isolation and treatment for medical team, not to the traditional method because many late cases because not go to the medical team and good management COVID-19 disease. And two, internal and reduction stigma from family, office, and community. support mental from expert, from the psycholog of the psychiater, support activity from supported team, friend, family, and supported group. Same my group from COVID, survivor COVID-19. And continuing education from stakeholder, government, and expert about COVID-19 disease. Because many stigma until here, uh, many people have the bad condition about the stigma and build good opinion about patient COVID-19 and this disease and continue carefully to spread it. I think important point, clear planning from the government to reduction COVID-19 with short and the long planning. I think if the all uh, important condition, external and internal, many people not stigma and survive in the COVID-19. Okay, thank you from this time. Thank you, team.
Thank you very much, Dr. Tri Maharani. And that brings us to the end of our presentations, three really quite different and very interesting presentations looking at the health aspects of the pandemic. We've got about 20 minutes now for questions, and I think I can hand over the questions session to Associate Professor Linda Bennett. Linda is a medical anthropologist based in the Nossal Institute for Global Health in the Melbourne School of Population and Global Health and a member of our IDeHaRI steering committee. So Linda.
Thank you, Tim. I'm hoping that all my technological difficulties are over. Thank you for the three speakers very much for your papers, and I'm sorry I wasn't there to start the session off with you. I think that we've been given three different important but different views about what's going on with health in Indonesia. We have two questions in the question box, so I'll start with them and then I might open it up a bit more widely if no other questions come through. So the first question I think is probably most suitable for Pak Iwan to answer, and that is regarded to the difference between city lockdown and mini lockdown. So the question is, from an epidemiological perspective, which one, city or mini lockdown, is more effective to contain COVID-19? He also says provincial lockdown, city lockdown, or mini micro lockdown. I'm wondering whether you have any evidence you can share with us on the impact of those different types of lockdown in Indonesia. Actually, yes, there you are, Pak Iwan.
Okay, thank you for the question. So we have the evidence of the lockdown, or we call it PSBB, in Jakarta and Indonesia, and then we correlate it with the new cases and also with the effective reproductive number. So we see from the previous PSBB that when there are less people going outside or many people stay at home, the number of new cases is decreasing. So it is obvious in the data. It is shown from the previous PSBB policy. But this is the PSBB policy for the whole city or the whole provinces. We don't have the evidence for the mini lockdown. But I think the mini lockdown also will have a great impact because it will involve the community. It will involve the people to do the voluntary lockdown and the community to control the transmission. But we don't have the hard evidence yet. That's what I can answer after the question.
Thank you so much. And that also touches on a point made by Dr. Pandu, which is one of the actions of the government that has been criticised has been the reluctance to involve the community. And I think those of us who've been following what's going on at the community level can see that that potential could have been utilised better. So on to another question, which I think all three of you could answer, but possibly Dr. Tri might be more suitable to answer, which is what measures can be taken to better protect healthcare workers themselves? So perhaps Bu Tri, you could speak to that first, and then our other speakers could add to that later.
Yeah, I think the good guideline from the COVID-19 reduction and protected many healthcare workers. One, guideline. Two is the PPA, the good PPA, March 9 and 95. I think it's very expensive now. And if the all healthcare worker have the mask, the good mask, I think many health workers protected from this condition. Guideline, PPA, and I think the other equipment, if the PRPR, if the HEPA filter from the room, negative pressure of the room, and the protective many healthcare worker. If the many equipment and many patient with the COVID-19. And I think it's very important is the extra fooding from the all health worker. Not only money in the good incentive, but is extra fooding, is the good food from the many healthcare worker, because many healthcare worker in rural area must buy themselves with the little money to fooding. If you
Okay,
know,
so the importance of nutrition for immunity. You just gave us a whole lot of really positive examples of what could be done. So it's really great that, you know, we know what to do. The issue is coordination and resources, but it's really great to have those examples to know what to do. We know that not every country has got that right, and that it does take both coordination and resources. Thank you. I was also wondering what Pak Pandu might have to say about protecting healthcare workers. Are you there, Pak Pandu?
Okay, thank you. Because start from beginning, we don't have system to protect or to educate the health worker. And when I was in Thailand in January, because I visiting some hospital to visiting the TB resistant activity there, and they are still have training, retraining all the health worker about the pandemic, how they how they can avoid, how to do the protections, and then what they needed to do, something like that. It means that they should be the system building the system in the healthcare, including infection protection system, that educations and also the PPA and also the nutrition supplement, something like that. That's important for us to know how we can protect ourselves even in our job in hospital or in our daily life, because the infection can be also come from in daily life. And then everyone in the hospital, in the healthcare system should be educated, because they know from the beginning, most of the COVID patients have asymptomatic or pre-symptomatic. It means that they don't need to, I want to be very careful when I dealing with the COVID patient, but not be careful with many patients. But actually it's wrong. This is the wrong idea. That's why the system should be there. But because we don't have the system, and we just focus on the PPA, just focus, then we forgot that every doctor doesn't know, or maybe doesn't have any, should be remind how to do that.
Thank you very much. So your focus is really on how important preparedness and planning is, not just response, but preparing our health workers for the response. So I'm aware we've only got 20 minutes. There's no more questions. Oh, yes, there are. There's another question in the question box. So we'll take one more. There is actually a question about, the enforcement of Pilkada regional in Indonesia during the pandemic. Do you agree about this or not? The biggest positive COVID-19 being tested from pesantren clusters. Sorry, the question is a little wonky, but that is to both Dr. Tri and Dr. Pandu. And that probably might be our last question, just so that we don't don't take up too much time for the next panel.
Yeah. I am in the rural area, and many even pilkada near me, near my hospital. I know it's very scary because many people not know this protocol of COVID-19, know what wear mask and the other, physical distancing and the other. And I think it's a bad policy about pilkada because the increase from the patient COVID-19. I think give my work very hard to the hospital and this community. And to the cluster of the pesantren. I living in Kediri, and Kediri many pesantren in here, and the big pesantren. One pesantren have 1,000 until 15,000 people in this pesantren. And you know, this one room, 10 until 20 children. It's the
That's a lot. Thank you, Putri. I'll also just see if Pandu can reply to that. I really understand that. And then again, linking it up to the other sort of points that you've made, again, preparedness, because if people in this community don't have anywhere to go, if you live in a pesantren and you don't have anywhere to go, you can't go anywhere. So a lot of these problems moving forward could be solved by better planning and better preparedness, and perhaps better religious leadership, where we talk to people about how we can protect the ummah, the whole ummah, and, you know, public health issues as an issue of Islamic responsibility. But let's jump on to Pandu, because that question was also addressed to him.
Yeah, about the pilkada is we cannot guarantee that pilkada is not have no effect on the increasing of the cases, because it's very difficult even to implement the regulation. They said that the regulation is there. It means that if they follow, but impossible to follow because they want to get together, gathering in the crowd, because we're dealing with, they just want objective, winning, become a winner. Then they don't care about the health. It means that they will do what they want to do. It means that in the start from beginning, even from still the first day for registration, they already make flock of people go together without using wear masks. They don't care. They don't have guilty feeling about this. They blame to the government. I never received the penalty or warning from government what I did or where the people like did. It means that it's very difficult that the pilkada will not have some impact on the pandemic. They will be increasing that the possibility. Also the candidate. Some candidate already infected, and some of them already died. It means that maybe I don't know who will become the winner of this pilkada. Maybe the COVID will become the winner.
Well, thankfully, we can always look forward. Listen, we're right on time, but we'll have one more question. It's a much bigger, broader question that I don't expect anyone to be able to answer fully. But the question is, what can be the role of ASEAN, or more directly Australia, in working together with Indonesia to support in pandemic preparedness and response? So might be good to hear from that, and I don't expect you to have all the answers. So thanks, Pak Iwan. That'd probably be our last question.
So I can respond that actually we can learn together from ASEAN country and from Australia. Actually, like from Australia, that what I know in some state in Australia have a good or better test and tracing policy. That's the Indonesia can learn from Australia about that one. So I think now it is important to learn each other from the country on how to control this pandemic together.
Thank you. I think, you know, DFAT is going to be putting money into that going forward, because obviously with infectious disease, it's in everyone's interest. And with the economy, it's in everyone's interest that we're traveling back and forth and being part of each other's economies and lives. So I just want to thank all three speakers again for a lovely panel. Really interesting getting those three different perspectives, and give everyone a clap. And I think we're going to move on to the next panel, but a segue. Thank you. A segue to that is really, we just had this panel that was very focused on COVID and health, and that's exactly what we asked you to focus on. But another issue also is all of the other health issues that continue despite COVID, and how the resources that have been directed towards COVID-19 may be affecting other critical health issues, and also affecting issues of inclusion and vulnerability. And I think that links nicely into the next panel that we have, that Dr. Ken Setiawan is going to be chairing for us. So thanks everyone, and I'll see you in the next panel.
Thank you.
Thank you.
Thank you.
Thank you, everybody.
Thank you, everybody.
Bye.
Round of applause for our panelists. And thank you to Linda for that current affairs anchor pass there. A beautiful segue into, I think you missed your vocation, into our next panel. I won't hold you up. Our next panel is to be chaired by Dr. Ken Setiawan, who is Senior Lecturer in the Asia Institute and another member of the steering committee of IDeHaRI. So I'll hand over for our next panel on health and society to Dr. Ken Setiawan. Thanks, Ken.
Thank you, Tim, and good afternoon, everyone. Linda surely has raised the bar for chairing. I'm not quite sure whether I can live up to that, but I'll do my best. So welcome to our second panel of today, and the last panel of this conference. I would like to introduce the first speaker, Dr. Ian Wilson, who's a Senior Lecturer in Politics and Security Studies and Research Fellow at the Asia Research Centre of Murdoch University. Ian, over to you.
Thanks very much, Ken. Can you all hear me okay?
Yes.
Great, okay. So I wanted to just try and give sort of an overview of sorts of some of the impacts of the pandemic on the urban poor in Indonesia. And there's already been, of course, a lot of commentary about how COVID-19 has really exposed and further exacerbated a lot of existing inequalities, both within and between societies. And globally, of course, the poor have been the hardest hit by the pandemic through the combination of both greater susceptibility to infection, often linked to the conditions of poverty, poor sanitation, crowded conditions, etc., but also intertwined very closely with the social and economic impacts that the pandemic has brought, in particular, a variety of containment measures that have been implemented by government. So if you look at the case of India, for example, and the very rapidly introduced lockdowns, you saw hundreds of thousands of jobless slum dwellers forced to flee their villages, and this was, basically a catastrophe. Indonesia hasn't had the same degree of impact among the urban poor, perhaps, as a country like India. I know, looking at some of the stats, that in Mumbai, for example, up to 40% of slum dwellers have been tested as positive with COVID-19, compared to only 15% elsewhere. And in fact, in some of the big urban centres in Indonesia, and I'll focus specifically on Jakarta, there's been almost an inversion of that, where the early sort of trajectories of the pandemic saw higher concentrations of infection, largely within middle-class areas of the city, and less so in poor areas, which some early analysis sort of linked to patterns of mobility early on. The sort of argument I wanted to present today, of course, very briefly, is that I think that there's been a lot of focus on the sort of patchy and often very incoherent response from national level governments in Indonesia regarding the pandemic and pandemic interventions. But there's often been a less reported degree of mass organisation and grassroots organising on the ground, and particularly in some urban poor communities. And I'd suggest that certainly at least one factor in explaining why the degrees of infection in some poor areas are far less than, say, in the case like Mumbai and other sort of mega cities throughout the world, has been that these early interventions by residents were really crucial. Unfortunately, however, not many of these practices have been integrated or even recognised by national or regional governments, and I'll suggest that that's really been a significant lack, and points to these sort of different scales of response that we're seeing, with a lot of emphasis on national government, but a lot of sort of positive stories on the ground of people working to mitigate the threats and impacts of the pandemic. So the urban poor, by the nature of being poor, are extremely resilient and adaptive, and sort of etch out lives from often an array of informal labour. Many of us have seen images of vendors, for example, street vendors in the midst of periods of political upheaval, terrorist attacks, still continuing to etch out a life for themselves in the streets of big cities throughout Indonesia, particularly Jakarta. Now, the pandemic, however, has sort of constituted a new sort of unprecedented challenge on that front for the adaptability and resilience of the urban poor, particularly as it's placed significant restrictions on accessing economic livelihoods that are based in public space. So the informal sector, by way of, for want of a broad generalisation, operates in public space, streets, around office centres, shopping malls, transport hubs, etc. And the sort of various levels of social restriction that have been imposed throughout the country, particularly in the case of Jakarta, have had very devastating impacts on the ability of the urban poor to be able to continue to make a livelihood while at the same time trying to mitigate the risks of infection. And one of the sort of major lacks that's been identified by some urban poor activists has been that a lot of government messaging, both national and provincial, has largely ignored a lot of these realities of the informal sector, where the call to stay at home, which for middle class white collar workers may be a pain, but it can of course be done, has been almost an impossibility for informal sector workers. And this has led to a mix of outcomes ranging from risky behaviour, where people just essentially are aware of the risks of the pandemic but feel they have left with no options but to continue to go out and try and etch a living selling their wares or providing services, etc. Or as we've seen with some of the statistics, throwing a lot of people into even greater levels of poverty. And I haven't got a slide for you, but certainly looking at some of the statistics of the World Bank, we've seen significant increases in poverty in Indonesia, and the national government has said that poverty elimination efforts have probably been set back at least a decade or so. So this problem of this kind of disjuncture between the kinds of messaging and the kinds of protocols that have been introduced by government and the realities of the urban poor has been a significant point of tension in that regard. And we've seen that even when some of the PSBB restrictions were eased in Jakarta, some of the sort of new normal arrangements pointed to a situation that's going to, if not addressed, lead to ongoing increasing levels of hardship. So we had things, for example, Jakarta's car-free day, where some major roads are shut off, where people are able to engage in exercise. They were suspended in March, reintroduced in June, and then shut down again with the latest restrictions. But when they were reintroduced in June, street vendors were no longer allowed. And of course, there's well over 3,000 street vendors that made a living through that kind of informal commerce. So this has sort of drawn attention to, I guess, a longer problem where the sort of policies and the politics around the regulation and organisation of public space, recognising that it's a space that's essential for access by the urban poor, and that this public health dilemma, in a sense, poses important questions of how to negotiate a path where people can still access livelihoods, but at the same time engage in the kinds of social distancing protocols that are considered necessary. Now, Jakarta hasn't been a great example for that, but there have been some good examples from around the country. And I point specifically to the case of Salatiga in Central Java, where local government ensured traditional markets could stay open for business while also maintaining—
Ian, 2 minutes.
Yep, protocols by moving vendors onto major streets, etc. So there is opportunities and there are examples of it where government-led policy can incorporate the urban poor in public space, but also to enforce or engage in health protocols. Unfortunately, a real emphasis has been on the policing of discipline in social protocol, distancing protocols, and we've seen, of course, the police, PNI, and more controversially, Preman and Ormas militia groups mobilised, which by many, I've been hearing anecdotally, has been a bad outcome so far for the urban poor. Just to sort of finish off, I'll shift the emphasis a bit, and I wanted to just talk briefly about some of the things that have been done on the ground, because I think really if we're looking forward, these kinds of initiatives really need to be recognised and engaged with by provincial and national level governments to develop comprehensive and sustainable responses. So in neighbourhoods I know in Jakarta, for example, we've seen forms of localised fundraising and crowdsourced funds to assist to help people to stay at home. We've seen local productions of hand sanitizer and hygiene products. We've seen networks of solidarity between urban poor communities and farmers in Kendung in Central Java to secure supplies of cheap rice. And we've also seen education campaigns that have been done by local residents and also groups like JRMK, Jaringan Rakyat Miskin Kota, to try and educate people in social distancing that's actually doable within the context of very densely populated communities. So to wrap up, and I look forward to questions and comments, you know, the pandemic has really highlighted existing inequalities and sort of the limited capacity of government in responding to social and economic health needs of large sections of the Indonesian population, in particular the urban poor. But we have seen self-initiated organising, grassroots mobilisation, and existing networks of solidarity and support of the urban poor, ones that have always existed, because being poor is an ongoing everyday crisis of sorts that it's been exacerbated by the pandemic. But unfortunately, we haven't seen this kind of link up between government responses and the kinds of often very effective but fragmented and localised responses from urban poor communities themselves. And as a way forward, I think there needs to be more sort of integration and communication of those different levels. And I'll leave it at that. Thanks very much.
Thank you, Ian, for your presentation and really highlighting some of the structural challenges that already marginalized communities face in the context of this pandemic. I would now like to turn to our second speaker, and in a slight change of the program, our second speaker is Ibu Cucu Saida, a disability inclusion advisor and initiator of Jakarta barrier-free tourism. Ibu Cucu, you have 10 minutes.
Okay, thank you. Hello, everyone in this room. Pleasure to be here today to share with you on what are the impacts of COVID-19 to persons with disabilities and how are we going to work on ensuring persons with disability are not left behind in response or taking actions. So I'd like to start with that because of the existing barriers, persons with disabilities become at high risk and the most impacted by the outbreak. So limited, for example, limited accessible information and its delivery regarding the COVID itself and social assistance, which make persons with disabilities are forgotten in the COVID-19 response. Although there are numbers of government social assistance adaptations, but only cover certain area and groups. The crisis had significant impact to persons with disabilities, losing their income, further also forgotten by the society or the community where they are. So I'd like to divide it into three sectors regarding the effect of this COVID itself. In April, in the late April, the Organization of Persons with Disabilities Network, where I joined also, we did a rapid assessment on impact of COVID to people with disabilities. That's we got 1,684 respondents, or individual with disabilities across the country, where 55% of them were economically active, and many of them have like in the informal sector, such as small enterprises, but those before the end, before the pandemic. And after the pandemic, 80% of them, they're losing their income, and some of them, it's found that they even difficult to cover their basic needs, such as for food. So the next is, although there are government social assistance from government, but only less than 14% were receiving conditional cash assistance, and less than 12% receiving unconditional cash assistance, and only less than 2% involved in the cash workforce program. Other than that, there's no information whether persons with disabilities are receiving those assistance. In health sectors itself, of course, that's first lack of awareness and knowledge of health services worker. It brings further expelling persons with disabilities to get their daily and necessity health service in regard to their disability, and for those who have certain health condition. The second thing is risks of infected by the virus, especially for those who need assistance in their daily life or even using assistive device. For example, I myself using a wheelchair use, it is a risk for me to go out using taxi or public transportation, because I cannot avoid somebody might touch my wheelchair, where my wheelchair is attached to my body as for my mobility. So, and in addition to that, for people who might need the personal assistance or carer in their daily life, of course, this physical distancing is much makes very hard on that. So support is really needed on this. The third thing in the health sector, inaccessible toilet and water facilities is also the problem, where even before pandemic, the barriers are exist, not only in their households, but also in the communal services, like in schools, offices, institutions, or pesantren or other boarding house, and even in the shelter camps, where people with disabilities who live in the shelter camps because of disaster, for example, they even facing double risk of COVID. And then this COVID or this pandemic brought into more problems, where access to clean water is the main issues for people with disabilities, and especially for women and girls with disabilities. And of course, with, as I mentioned, people who need assistance or who need a carer, and then people who need mobility devices, or people who are blind, who mostly has to touch the surfaces. And in other sectors, such as in education, we found that lots of online learning materials are not accessible for students with disabilities. This is, of course, that creates more challenges for families who may taking care of them, and then facing the abuse is also a risk on this. So I believe these these serious situations, those are issues that I've mentioned that we need to take together. We need to take an action. Because the conditions, of course, become double burden, especially for women with disabilities who might also heads of households, losing their dignity, because then it creates dependency. And for girls with disabilities, will even putting them in a risk because of those barriers. Of that situation, I'd like to give some like a few recommendations that we might take into account in our work. The first is the importance of engaging people with disabilities, their organization and their disability movement, which is the organization of persons with disabilities need to involve, needs to engage and play a role in sensitizing governments, development actors, or humanitarian actors and intellectuals as well. So this is also important to emphasize the roles of persons with disabilities and their respective organization, not just a passive recipients of aid, but actively contributing to the response. The second, the work should consider diversity, which means respect and adapt it to local context and local culture as well. The third is that, as in the beginning I've mentioned, that it is important to provide information and communication to be accessible for all. Having different formats of information, such as in audio, sign language, in visual, video, in easy to read formats, in any different kinds of formats of information is very important to have this. And then also, of course, it's also important how do we deliver this information, because up until now there are lots of information, like tons of information coming from social media, but whether it's
2 menit ya, Bu.
Yeah, okay, Bu. So those are very important. And the next recommendation is the inclusive response and programs and budgeting. It's very important. And then the last one, safety and accessibility on locating to access to water and public facilities, especially to think about the women and girls with disabilities who are at most in this situation. So I think that's all. Thank you. 10 minutes. Thank you. And then look forward for the questions.
Thank you, Ibu Cucu, also for staying very much within time, but also raising some of these, some specific things that we can look at and that we should consider in a pandemic response towards people with a disability, and also to ensure that people with a disability are not just passive recipients of as you put it, not just passive recipients of aid, but really included as active agents in this response. We will now move on to our third and last presentation. In the meantime, I would like to ask all participants if they have any questions to start, put them in the Q&A box, which we can then use for our discussion. So our third presenter is Andi Yentriani, who's the chairperson of Indonesia's National Commission on Violence Against Women, Komnas Perempuan. Andi, you have 10 minutes. Thank you.
Thank you, Ken. And thank you again for the committee to invite me to speak before this very important forum. And allow me to firstly apologize to the committee for all the hiccups in the preparation of this speaking, because the pandemic has posed unprecedented challenges to the institution. And I think although it has been like, what, 10 months something, I haven't mastered the rapid changing of tasks that I have to step in due to the development of the situation. Now, secondly, I want to actually talk about the experience of women in facing violence and discrimination, but reflecting on the cases that we have received since January up to date, I would argue that the COVID-19 pandemic not only exposes and deepens the existing problems regarding services for women victims of violence, but at the same time, it renders other threats to women's security invisible. So allow me to share screen with you to make my point clearer on that matter. So let me start by introducing Komnas Perempuan very briefly, since many of you may not actually familiar with it. It is a national human rights institution with a very specific mandate to eliminate violence against women and the promotion of women's rights. It was set up in the aftermath of May 1998 tragedy. So you can say that anti-sexual violence is basically in our DNA. And it actually asked to follow both CEDAW and Convention on Anti-Torture, besides our constitution as our legal framework. Now, I myself and other 14 colleagues of commissioners resumed the position in January 2020. And in January, we decided to have 5 priority issues in which we are calling for women in conflict and disastrous situation. However, we didn't predict that pandemic COVID-19 would be a very major challenge in our function today. Just as a very brief also introduction to the structure, we have 15 commissioners, and actually according to our presidential decree, we are only allowed to have 45 staffs. So the other 35 is actually funded through international grants. And we have to serve at national level because we do not have regional offices. So imagine that in time of COVID-19 pandemic, when we learned that Indonesia is hit by the pandemic and the policy for restriction of movement is going to be installed, we look at our data, and it appears that annually, the rising report of cases of violence against women shows that the majority are domestic violence. Now, shall all women are being put into the house, we anticipated that the majority of cases to be reported in the time of pandemic will be domestic violence. And since everyone will be more online, we are also expecting an increase of online gender-based violence. And also the economic impact might actually resulted in more exploitation of women workers, particularly those in impoverished situation. We are also expecting lower number in report and delays in handling cases due to the restriction of movement. And in the same time, we rely on, if I can say so, an active agency from women, including women human rights defenders, to create a creative strategies in response to this situation. So what we did is actually we firstly do an online survey of changes of household during the pandemic, and also another questionnaire and reviews on policies, and also we do FGDs with various stakeholders. Now, according to our online surveys, there is an increased tension with spouses. I won't bore you with all the statistics. You may actually have the presentation after this. And we learned that the economic condition contributes to the potential domestic violence, and women are more frequent in experience all forms of violence. And the form of violence experienced by women are similar to those experienced by other members of the family, in which daughters are more often in experience violence than sons. So we also work with the Commission on Child Protection, and they have their own survey confirming the impact of violence of women during the pandemic to the violence of children at home. Now, if you look at the cases of violence against women during the pandemic, actually we have received more than 107 1,700 cases, which is much higher than the cases that we received over 2019. And as we anticipated, mostly are domestic violence, as well as sexual violence and online sexual violence. We also gathered reports from other institutions and all actually confirm about this pattern of domestic violence and sexual violence. Now, if we look at the capacity to respond, unfortunately, it is an ongoing condition that despite the growing number of service providers, we still observe that it is only available mostly in Java and at the cities. And many of them is actually having a segregated and partial perspective in handling the cases with a very limited capacity. And in the same time, the victims and defenders who are reporting the case are still at a risk of criminalizations. Now, we actually learned and also review policies that being issued during the pandemics. And in the same time, we actually see that despite all of these policies that being issued by Ministry of Women Empowerment, Ministry of Health, Supreme Court, Attorney General, Ministry of Law and Human Rights, even Ministry of Home Affairs, to encourage more regional role to prioritize services to prevent and handle violence against women and children, including in the budgeting. Improvements on the condition of the services has been very slow. Hence, it actually deter the services to be able to provide an optimal services during the pandemic, particularly because during the pandemic themselves
2 minutes.
are not allowed, are not able to to go and limit themselves to just only receive online. However, when they have to go out, they have to actually spend their own budget for meeting the health protocol. Now, just allow me to attract your attention to the other three contexts that I really want to look at because it becomes invisible during the pandemic. One is the growing religious intolerance in time of pandemic. And we learned that none of the, or if I say, majority of discriminatory bylaws are not withdrawn. Sorry, most of the discriminatory are not withdrawn, despite Ministry of Home Affairs and Ministry of Human Rights effort to clarify. So this is a typo, should be are not withdrawn. And very few disputes on places of worship are resolved. Whilst during the pandemic, we have received reports of cases of intolerance. And we learned that women have a specific experience of violence and discrimination in this kind of context. I also would like to highlight that more and more women are using body as the weapon to struggle when they are in the conflict related to development of policies and programs. These are the three major conflicts that being reported to Komnas Perempuan, where the women actually strip themselves off in their efforts to stop the development. And reflecting on the other cases, the 57 cases that we received during 2003 to 2020, women face sexual harassment and assault, as well as the usage of sexual baiting and gerwani as a stigma, besides other burden they have to endure. And it actually increased the direct and indirect health risk they need to face during the pandemic.
Andy, can you please wrap up?
Yeah, so I just want to wrap up, then look at the way forward. I think there are 6 key policy of recommendations, which is, I will talk further in the discussion, but I just want to highlight that there is a need for a systematic perspective, a monitoring and evaluation in a more rigid and thorough approach, affirmative measures, including the issuance of anti-sexual violence law, and better protection and support for victims and defenders, utilizing technology for integrated criminal system, and also coordinating and budgeting. I think Ian and other panelists, Mbak Cucu also mentioned this. So I will end here and also look forward for the discussion. Thank you.
Thank you very much, Andy, also for once again highlighting how important it is to take a gender perspective to the pandemic, to fully understand its impact and also from there look for solutions. So I'd now like to open the floor for questions from our audience. I will start by a question that has appeared in the Q&A box, and I would once again remind all attendees to, if they have any questions, to write them there. The first question is for Ibu Cucu Saida and Ian. What, if any, role has or could the local government structure and personnel of RT, RW and Lura play in identifying needs and assisting people at the community level?
Okay, maybe I could start. Thanks for that question. I think that that's been an utterly crucial level of governance, and if this pandemic has shown anything, it's that there's often a clear gap between the concerns of national government and then the local levels of government that are more focused on everyday problem solving for their constituents and their residents. And so certainly the RT and RW level, I know in Jakarta that from even in February, when the national government was still, not even recognizing that this was a genuine threat, you had local neighborhoods via their RT, via their RW, engaging in their own version of kampung lockdown, where they were sort of redeploying, I guess, security practices to sort of screen who's coming and going from their neighborhood, providing sanitation. I also know in Jakarta that RT and RW have been really crucial in compiling data and information on residents in relation to COVID-19, some of which has been fed into Lapor COVID, which is an online resource that is a sort of a citizen-driven resource, but also linked to government. So I think those lower levels of government, and I should say there's recently a very good article written by Rebecca Meckelberg and Sharon Ball looking at scalar politics in COVID responses, and seeing that at this very local level, there's been a lot of ingenuity, a lot of actually pragmatic and effective solutions. And again, as I tried to highlight in my talk, a real disjuncture between that and the kind of incoherence that we've seen at a national level. So to answer your question, I think that's been really crucial, that level of governance.
Thanks, Ian. Ibu Cucu, do you, what is your take on this? What is the role of local level government?
Yeah, thank you for the questions. I think, yeah, agree with that. That's the local government from RT, RW and Kelurahan or Desa are very important on this, identifying not only the needs, but ensuring the distribution of the assistance, for example, gets into the people who needs it. And then in fact, that's numbers of organizations of persons with disabilities who are working in the grassroots level. Yes, they are working very hard in ensuring that their community member are taking into the account, especially to get the social assistance from the government. So most of them, they are working with kelurahan or kepala desa, where I think there are like a budget on that for the social assistance. However, again, for people with disabilities who are or even in the for people with disabilities who live in the community or in the village or in the in a society where there is no organizations of persons with disabilities active doing it, again, are still needs to be needs to be to push that local government has to work on that. it's been noting that in the recent, I mean, in these situations, now the disability movement, especially who are in the grassroots level, now are taking, it's quite improving to make sure that their members are receiving, I mean, are included in the programs or in the response, and receiving the information such as the especially in the COVID response, in the COVID information, things like that. Yeah.
Thank you. So if I could kind of summarize, you're both saying, you know, the local government is actually filling really important gaps that are not adequately addressed at national level. But at the same time, as you are saying, you know, there's still limits to the sensitivity of that response, particularly with regard to people with this disability. Andy, do you have any, can you further add to this?
In the experience of services for women victims of violence, the local authorities, even RT/RW, actually play a very important role because it is actually the first you know, like place that the victims can go. And if we look at the survey that we did, most of the women did not actually save contact numbers of the institutions. And hence, we also learned that many women organizations working with women victims are actually advocating for the village budget to be utilized to also address the need of the victims, particularly because like in gathering evidence such as visum et repertum or even DNA test are mostly paid by the victims. So yeah, I think it hasn't really got the attention from the national government. And I have also learned that there is a discussion, the ongoing discussion to revise the law on village, and hopefully it will provide a larger authority for the village leaders to also play the role to prevent and handling cases of violence against women.
Thank you, Andy. The next question is directed to all our three panelists. And the question is from Linda Bennett, and whether you could talk about how people without legal identities or formal citizenship have been adversely affected by the pandemic. For instance, children who live on the streets, trans women and HIV positive Indonesians, many of whom who don't have identity cards.
Yeah, if I could start off, that's been, I know in the case of you know, urban poor in Jakarta, a significant problem. There has been, you know, some government responses in terms of the delivery of sembako packages for those who are registered as poor. But of course, the reality in a lot of neighborhoods is that people aren't registered. They fall through the gaps. Either that or the statistics are just fundamentally wrong. I heard from, you know, friends in Jakarta that there was a sort of a logistical nightmare in terms of revealing the lack of adequate documentation, and also the fact that a lot of urban poor are highly mobile in the sense that they may move between different parts of the city, they may reside across a number of addresses, their workplaces are spread, and that this has been exposed as a real problem in terms of the delivery of government related aid. In the case of JRMK, the Jaringan Rakyat Miskin Kota, they've, you know, sort of specifically tried to address some of this, firstly by providing advocacy for people to be recognised, but also through their own means, where, you know, they've done crowdsourcing to distribute cash to people who are in immediate need and allow them to stay home.
Thanks,
May I add
Ian.
to that?
Yeah, sure. Go ahead.
In one of our review, which is on the security welfare scheme, we conducted an focus group discussion with transgender LGBT community, as well as sex workers and HIV positive people. And we learned that most of them are actually supported by their own community because of the problem in accessing although they have the identity card, for instance, but the different gender expression may actually deter them from having the access. There is also a concern of a reduced access for medication for friends who are positive HIV/AIDS, and we have communicated this to the Ministry of Health. So hopefully it's going to be not being negotiated with the budget for handling the COVID-19 pandemic. And on issue of legal identity is also being faced by those of religious minority, particularly the Ahmadiyya, who are not allowed to register their marriage. Hence, they are not able to register or to have the child certificate and so on. And this actually influence their access to support for online learning for their children. So all of these are, we are still in communication with the national government, and hopefully it can be addressed adequately.
Thank you, Andy. Ibu Cucu?
Yes, to people with disabilities, regarding the identity card, it is still a huge problem, even before pandemic, because of the stigma. So there are a lot of people with disabilities that they don't have identity card. Even, for example, like children with disability, lots of children, they are not included in the the family card because of the stigma. So again, what in the beginning, my talk, why then people with disabilities have become a high risk in this COVID, not because of the condition, the individual condition, but because of the barriers existing. And one of the things is stigma is a big barriers that are exist, and then being and affected by COVID even worse. Yeah.
Thank you. I think all your answers really speak towards the issue of how central legal identity is for people to claim their basic rights and also to have access to social services. I'd now like to move to another question to Ian. This question is from Inaya Rahmani from UI. She asks, you mentioned on grassroots recruitment of preman for security. How do you see, based on your work, on the urban poor as well as preman in Indonesia, this develop and play out in the near future, specifically in local elections?
Okay, yeah, thanks, Inaya, for that question. You know, I really, like everyone, I wish I was in Jakarta at the moment where I could give you a better answer to that question. But it really depends a lot on, in terms of the recruitment of preman, and of course that's been a controversial policy to utilize existing wielders of localized authority as agents of policing COVID protocols. And my understanding of this is that this has really had variable outcomes depending on the group and depending on how they perform or behave. So by way of example, the Forum Betawi Rempuk, which is a big ethnic militia in Jakarta, you know, they've worked actually pretty closely with some local vendors because they're very much embedded in the community and have tried to police COVID protocols in ways which aren't detrimental to people trying to make a livelihood, because it's their neighbours, it's their families, etc. But you have other groups that are more aspirational to power and embedding themselves within policing processes institutionally, like Pemuda Pancasila, for example, who've been extremely enthusiastic about this. And I think that's had some negative outcomes from what I'm hearing anecdotally, but also, as you suggest, could have significant implications for the Pilkada, both in terms of groups like Pemuda Pancasila have been extremely pro-regime, pro-Jokowi, and there's a lot to suggest that they'll be using what they see as a mandate, a kind of a state-ordained mandate for policing in a political way. I think that's how that will transpire. I'm not sure, but I certainly know from conversations that I've been a part of that they're very much seeing this as a great opportunity in many respects. Thanks.
Thank you, Ian. Maybe there's still time for one short question that I'm taking from the Q&A box. The question is for Andy. Andy, there's a question from Nurul who's asking, based on your research data, what is the potential for women's violence and the high risk of marriage and divorce from upper middle income and poor communities?
If we just based on the survey, actually the tension, the spousal tension is more experienced by those from lower income, like spouse. But also in the same time, we actually observed that more than 70% of those who are not reporting the cases of violence against women are those with higher education, minimum bachelor degree. So we have not been able to review the cases of divorce from the religious court as well as the public court. So I wouldn't be able to say so. But I would say that if we look at the trend from previous years, it can be actually from the poor communities are much higher than the upper middle income, partnership to be divorced. But actually our attention is also about the early marriage that being conducted during the pandemic. So there has been report of request for dispensation to religious courts registered by the parents or by the teenagers themselves, claiming that they do not have anything to do during the online learning sessions, hence they prefer to get married. So we are looking more closely on this incident to be,
Thank you very much, Andy. Due to time, I have to close this session. I would like to thank all our three panelists for their contributions and their great insights. I think, all of you have spoken very well about the immense social challenges that come with this pandemic, but at the same time, you also really touched on community resilience and the creativity and strength of people through all of this. So thank you very much. And I hope we can have more opportunities to discuss in the future. I would now like to hand over to Dr. Helen Pausacker to close the conference.
Now, can you hear me now?
Yes.
It's always a worry, isn't it? So it's my great pleasure to thank everybody. Firstly, the speakers. So yesterday, Marcus, Pak Mugis, Ibu Bibib, Ibu Inaya, Pak Wahyudi, and Pak Nadir. And today, Pak Iwan, Pak Riono, Ibu Maha, Ian, Ibu Andi, and Ibu Chuchu. We were very grateful to be able to get such a wide view from you on Indonesia's response to COVID-19, ranging from political, legal, and through to medical, and today's social and effects on communities within Indonesia. We also appreciate that speaking at a conference like this is very difficult because you're talking into your computer, you can't gauge what the audience reaction is. So we're particularly appreciative that you were prepared to talk with us. On the other hand, one of the good things of online conferences is we would never have been able to have such a wide range of speakers if it had have been a case of inviting you all to Australia. But unfortunately, we wouldn't be able to do that, but we've been fortunate to hear you, and we hope that sometime we'll be given big funds and we can invite you all in person. I'd also like to thank all of the chairs, Dave, Ken, Linda, and Vedi, for doing a wonderful job in chairing this conference. And behind the scenes, I'd like to thank particularly Catherine and Debbie, who've had a mammoth task in pulling everything off, and also Tim Mann, who helped with it. Finally, I'd like to thank the audience and apologize. Usually we would provide you with snacks, and we did contemplate sending them to you via courier, but we decided that Melbourne University's budget didn't go for that. But we hope that it won't be too long before we can gather together and actually have snacks with our talks. So thank you everyone for attending and everyone for participating, and to everyone who organised. And I hereby declare the conference closed. Thank you.
Thank you.
Thank you, everyone.